Good afternoon, and thank you for joining the RLS Foundation's webinar titled Neurostimulation and Restless Leg Syndrome. My name is Carla Diezenkowski, and I'm the Executive Director of the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Winkleman will answer as many questions as time allows at the conclusion of his presentation. After the webinar, you will receive an email with a link to the webinar recording. The webinar recording will also be made available in the member portal section of our website. If you are not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. John Winkleman. Dr. Winkleman is Chief of the Sleep Disorders Clinical Research Program, Department of Psychiatry at Massachusetts General Hospital in Boston, Mass. MassGen is the newest RLS Foundation Quality Care Center to join this network available around the U.S. and in Europe. Dr. Winkleman received his PhD from Harvard in psychobiology and his MD from Harvard Medical School. He finished a residency in psychiatry and fellowship in neurology at MassGen. He has served as chairman of several national organizations, including the Nosology Committee, the Movement Disorders section of the American Academy of Sleep Medicine, and the American Academy of Neurology Guideline Committee for the treatment of RLS. Since 2000, he has served on the RLS Foundation's Medical Advisory Board that is now known as the Scientific and Medical Advisory Board. Dr. Winkleman's research interests include sleep-related movement disorders, insomnia, and parasomnias. He is a leading expert in the field of RLS, has published several textbooks, and has authored over 100 articles in the field of sleep medicine. Dr. Winkleman, we thank you for sharing your time and expertise with us today. I now invite you to begin your presentation on neurostimulation and restless leg syndrome.
Thank you, Carla. And I want to welcome everyone who's listening out there to this presentation. This is a really novel area in sleep-related movement disorders, particularly in restless leg syndrome. And as you'll see, there's not a ton of data here, but I'm going to present what exists on the different techniques that have been used to stimulate either the brain, the spinal cord, or the peripheral nerves. I would consider this an introduction to this field. None of these treatments, or just about none of them, are really ready for prime time yet. But I think that it's good for those people who suffer from restless leg syndrome to be aware that these treatments do exist, and that hopefully over time there'll be more evidence of whether they are or are not effective for restless leg syndrome. And here you see my disclosure slide, and take these potential conflicts of interest into account when you're listening to the contents of my talk. At this point in time, as those of you who are listening are probably fully aware, there are a number of known effective treatments for restless leg syndrome. When we initially evaluate somebody in the office, we assess whether there are known reversible causes of restless leg syndrome, in particular iron deficiency, or medications that can worsen or in fact produce RLS. We also have a number of medication approaches, some of which have been FDA approved. The dopamine agonists include pramipexole, ropinirole, and the rotigotine patch, all FDA approved for RLS. The alpha-2 delta ligands include gabapentin, gabapentin anacarbol, and pregabalin. Only gabapentin and acarbol has been approved for RLS. The opioids, which include a number of members, but most commonly oxycodone and methadone, neither of which have been FDA approved for RLS. And then iron treatments, either oral or intravenous iron. Intravenous iron has not been approved for RLS by the FDA. Given these existing treatments, you'd think that everybody with RLS would be well treated. Unfortunately, that's not true. Many people with RLS continue to suffer for a variety of reasons. For people who have used dopamine agonists, over time these medications can make the underlying RLS worse, what's known as augmentation, or people can have a loss of efficacy over time with these dopamine agonists. Not that the RLS gets worse, just that the medicine doesn't work as well. They also can have side effects, which can limit the use of these medicines. In particular, nausea, sleepiness, and I'll mention two others, which are weight gain and exacerbation of mood disorders. All of those things can, I'm sorry, that's not for the dopamine agonists. That's for the alpha-2 delta ligands. I was getting ahead of myself. For the alpha-2 delta ligands, most common side effects would be sedation and dizziness. You can also see weight gain, as I just mentioned. And I did want to mention as well that some people can have a worsening of a mood disorder on these medicines. With the opioids, there are concerns about risks of abuse, respiratory suppression. A common problem is constipation, and sometimes sleepiness can interfere with the use of these medicines. So given that existing landscape for the treatments, we're always looking for new things to treat people with RLS. And one of the things that is being considered are neurostimulation techniques. And why would you ask, might these be considered to be effective? Well, by definition, RLS gets better with movement. And movement can be considered a form of neurostimulation. So we know that there are some types of stimulation that are helpful for RLS. The question is, can we mimic those without requiring people to move? We also know that from people with significant pain or significant itch, that what's known as counterstimulation is helpful. Both either before the pain or the itch or after the pain and the itch. If you bang your thumb with a hammer, one of the first things you're going to do is rub it, which somehow seems to relieve the pain. People with RLS have used these kinds of techniques for centuries probably. Massage, people will be very vigorous in hitting their legs, use hot water, exercise. So all these forms of counterstimulation have at least some benefit for the RLS symptoms. If we look in terms of what causes RLS in the brain, or what we think does, we can see that there's some justification for using these techniques as well. What we know about the central nervous system is that it is hyper-excitable in RLS, particularly at the level of the spinal cord. And if we can modify that hyperexcitability with some kind of stimulation, we may be able to relieve RLS symptoms. Similarly, there are theories that RLS is due to abnormalities in blood flow in the legs, which might then lead to low oxygen in the legs. And the belief in these people is that the effectiveness of movement is because it increases the oxygen supply to the legs. And it's possible that we can increase the oxygen supply through other means, and particularly with various kinds of neurostimulation. So I want everybody to think about RLS, similar to other sensory motor experiences, unpleasant ones, including pain and itch, which involves both the peripheral nervous system, central nervous system, this abnormal feeling, relief, at least with itch, with movement, and as with a strong emotional component. RLS is not just the urge criteria, but has a very strong emotional aspect to it. And again, in this way, it is similar to both pain and itch. And the reason I bring this up is because these TENS devices, transcutaneous, which means across the skin, electrical nerve stimulation, has been used widely in physical therapy to address pain symptoms. And TENS, as you can see here, is just the application of a mild electrical current, usually just provided with a 9-volt battery, so it's not high voltage, to the skin nerve fibers using electrodes that sit on the skin. And usually you increase the intensity of the current to just above where people can feel it. So people have a lot of experience, particularly in physical therapy, using TENS devices. However, when these TENS devices were evaluated to see whether they're effective in pain syndromes, the data is not so good. And here you see from the AAN a couple of years ago, there was strong evidence that TENS is not effective for the treatment of chronic low back pain. For painful diabetic neuropathy, there is good but not strong evidence, not the highest level, that TENS could be considered for the treatment of DPN, or diabetic peripheral neuropathy. So TENS has a mixed history in terms of pain syndromes, but for diabetic neuropathy, there does seem to be reasonable evidence that it's effective. And this is really the bottom line for RLS. Brain stimulation, or for that matter, spinal cord stimulation, or peripheral nerve stimulation. I could just say here, neurostimulation has no proven efficacy and unclear safety in restless leg syndrome. But given that caveat, I'm going to introduce you to the different studies that have been done. One of the studies uses something called transcranial direct current stimulation. So low current, low voltages of current are applied across the skull. And here you see a number of kind of cartoons of this. And you have a stimulating and a non-stimulating electrode on opposite sides of the head. And you can see in the kind of the far right figure here that you actually can change brain activity using these low levels of current across the skull. And the question is whether this would be effective for RLS. There was a study done here, I think it was out of Korea, where they stimulated the primary sensory motor area. So this is an area on the cortex where they stimulated in a double-blind, sham-controlled study of 33 people with severe RLS. What sham-controlled means is that, when you do drug trials, you use placebo. So what they're trying to do here is come up with some kind of placebo. And of course, it's not going to be a pill. You want it to be something that would be on face value similar to the active stimulation. And so sham stimulation, you give all the same electrodes. You may even give a little teeny bit of a current, but it's well below what you think will be effective. And they stimulated at these different spots at very low voltage for 20 minutes, 5 times over the course of 2 weeks. And you see here the sham treatment. The further down the bar gets, the better the RLS is getting, because that's a reduction in the IRLS score. And the sham treatment here, you see, was as good as this transcranial stimulation. So from this study, there was no evidence, at least in people with severe, that transcranial stimulation was effective. Here's another study, just a couple of years old, from Germany, where they did, again, transcutaneous electrical stimulation, but not at the scalp to stimulate the brain, but this was at the spine. And so again, this is sham controlled, and you always want to do these studies in a controlled fashion with 20 subjects with severe, or patients, I can call them in this audience, with severe RLS. And they had a stimulating and an inhibiting arms here, where they tried to tried to see whether it was effective. And for the real stimulation, they gave it for 30 minutes. For the sham stimulation, they only gave it for 40 seconds. And this was down at T11, so about 2/3 of the way down the back. And I'm probably not going to get into all these details here, but what they found was that one of the abnormalities they had seen in hyperexcitability of the reflex, there's a certain reflex when you stimulate the tibial nerve, the hyperexcitability that you can see in the left part here, the purpley blue color, you can see had a much more robust reflex than the people without RLS. And then after they gave this spinal stimulation, you can see that they were able to reverse this robust hyperexcitability that was seen in RLS. Now, this is clearly not improvement in RLS. This is just a change in a reflex. But the authors consider this as a promising first step, and I think the idea is then to move forward to see if it can be helpful in with RLS symptoms. The next type of stimulation that we're going to examine is what's known as transcranial magnetic stimulation, or TMS. This is not TMI, which is too much information. This is TMS, which is transcranial magnetic stimulation, and this has been approved for use in resistant depression. And it is a very interesting way to stimulate the brain. So rather than using current, electrical current, which has to cross the skin and the scalp and the dura and the cerebrospinal fluid to get to the brain, you use a magnetic field. And once the magnetic field gets into the brain, it gets turned into an electrical current. So magnetic fields, when they pulse, turn into an electrical current. And so this magnetic field kind of is like a, what's the word with a Trojan horse. You stimulate magnetically, but once you get into the brain, you've got an electrical current. And here in this one study published a couple of years ago, again sham controlled, 19 people with RLS. They used TMS every 3 days for a month to one part of the brain and the motor part of the brain. And they found really very significant benefit of TMS for RLS. And you have put a box here around the data here so that you can see in the sham stimulation group over on the left, there was basically no change from baseline, whereas in the quote-unquote real stimulation group, there was a very dramatic reduction in RLS severity, and both of these groups started out with quite severe RLS. So this is very promising data. I think that we'll need to see some confirmation of this before we can start using TMS for the treatment of RLS. Here from a Chinese group, this is an open label study, which are always suspect because everybody knows they're getting getting treatment. And given that RLS does respond to placebo quite well, we have to, I'm not going to spend much time on this, other than to say that, again, TMS in this open label study demonstrated efficacy for RLS. I'm just going to touch on deep brain stimulation because I think that this is something that very few people will want to pursue. But these were implanted electrodes deep in the brain here near the thalamus for people who were using DBS for either very, very bad RLS or for Parkinson's disease. And there were mixed results with the deep brain stimulation for RLS. And so I'm not sure that this is a direction that most people would want to pursue for a variety of reasons. I did a study that we presented last year using a TENS device, which is commercially available. You can see here where the device goes, just below the knee with the stimulating electrode. You can see there are a number of these kind of little black flat spheres. There's stimulation all along the lateral part of the leg because the stimulating electrode, you can't see it, is underneath 3 or 4 of those spheres. Again, this is an open label study. We only did 9 people. And as I said before, open label studies are not particularly, don't provide significant insights into the benefit. The idea was just to see whether people could use it and whether we got any improvement at all. And in fact, we did see some improvement. 6 out of the 9 people said that they had much or very much, were much or very much better. Their IRLS score improved, using it an average of about 3.5 hours a day for a month. But again, until we get some data where we can test this against a sham TENS device, i.e. have some people get real TENS and other people get TENS either at a much lower level or for shorter periods of time, we're not going to be able to really say whether this is effective or not. You may have seen advertisements for some of these devices on the internet, either pneumatic compression devices on the left, which either pump air or water through a device, kind of like a cuff around the leg, and if you will, massage the leg back and forth and back and forth. The other approach would be to use vibration, and here you see this is not the actual device, but you can see it's a smaller kind of pillow-like device that goes under the legs and basically jiggles the legs like those old-fashioned that you'd get in the motel that when you went to with your parents. Why would these work? Well, either they're producing the same kind of benefit that neurostimulation or counterstimulation provides, kind of like massage or rubbing the leg or hitting the leg, or they may provide some benefit through stimulation of opening up blood vessels and increasing oxygen supply to the tissues. And of all the things we're talking about today, the pneumatic compression devices have the most evidence for their efficacy. In recent guidelines published by the AAN, we said pneumatic compression is likely effective in the treatment of patients with moderate to severe restless leg syndrome. Here you see a device that was similar to one used in this study. And you can see here, let's just look at the third set of bars over from the left, the IRLSSS, and you can see the pneumatic compression device produced a significant improvement here. So the higher up you're going, the bigger reduction in RLS symptoms there is. And the hatched one was the sham device, which only inflated a little teeny bit. This next slide here refers to data from the vibratory stimulation. This is also commercially available, known as the Restless device. The data is published, as you can see, in the Journal of Parkinsonism and RLS. They did 2 large sham-controlled studies in patients with moderate to severe RLS. They used the vibrating pad in the arm with the active stimulation for 35 minutes under the legs at home. Unfortunately, there was no evidence that this worked for RLS. And I want to be very clear about that. You can see that the reduction in IRLS scores with the vibrating pad were a little over 6, as were the reductions in IRLS scores with the sham pad, the pad that didn't vibrate but had other kind of bells and whistles that made people think something was happening. So unfortunately, this Restless device does not appear to work for RLS. On the other hand, there was a benefit of the Restless device for sleep. So it didn't help us, it did help people sleep better. So that there's some advantage to that for sure. The next type of device that I'm going to mention is a near-infrared stimulation. And the infrared, here's the different wavelengths of light, and you can see the visible light there in the middle with the pretty colors. And infrared has to do here with longer wavelengths of light, which are not visible to the eye, but which can pass through the skin. And the theory is, and I think from my reading, this is just theory, is that this increases blood flow in the area that is stimulated. And in one study published about 5 years ago, again, a sham-controlled double-blind study of 34 people, here with mild RLS. They had 12 30-minute treatments to the lower legs over 4 weeks, so it was 3 times a week for 30 minutes. And there was a greater reduction in the IRLS score at 4 weeks than with the sham device. So I think that, like some of the other treatments, this is a potentially promising approach. It did require quite significant time commitment with going to a place where you got these treatments 3 times a week for a month. But you can see that it did seem to produce a superior benefit than the sham treatment. And I think this may be one of my final slides where they tested the efficacy of acupuncture for RLS. And again, we can consider this as a kind of neurostimulation where the needles are placed along meridians that, to be honest, I don't understand, and that produce benefits even well at a distance from the site of the needle insertion. And here they chose sites in the group with the black filled circles. They chose sites that they felt would be good for RLS, probably those referring to the legs, but I think that they were individualized according to the distribution of patient symptoms. And in the group with the white circles, they put the needles in random locations that were not based upon the distribution of people's symptoms. And you can see that the standard group had better reduction in the IRLS score, which is a severity score for RLS, than the sham treatment. What worried me about this study is the fact that usually sham treatments, placebo, produce fairly decent benefit. And what worried me here is that these are people who went 3 times a week for 6 weeks, and you can see that they had no benefit, just about no benefit, of sham acupuncture. And maybe it's because they were on the moderate to severe range, but I like to see some kind of benefit of the placebo group to know that the patients were truly blind as to what kind of treatment they're getting. So this is my last slide. In summary, as you know, RLS is a neurological disorder. We think that there's underlying hyperexcitability at multiple levels of the nervous system, certainly at the spinal cord and probably at higher levels as well. And the thought is that electrical or other non-pharmacological stimulation, whether it be pneumatic compression or acupuncture or near-infrared light, may be able to diminish this hyperexcitability or increase blood flow if you think that that's a mechanism for RLS, and that might mimic what people are doing themselves to get relief, which is basically getting up and walking around or jiggling their legs or something like that. And that's the idea behind these stimulation techniques. We know how to get rid of RLS, which is just to move around. The problem is that you can't move around all the time, and you certainly don't want to move around all the time. You want to be able to sit on a plane. You want to be able to get your hair done. You want to be able, certainly, to lie down at night and sleep and not have to move around. So if we can mimic whatever we're doing naturally by moving with some kind of stimulation, we'll certainly be able to provide people with an excellent alternative to existing therapies. On that note, I'm going to take questions, and I think Carla will be reading from a list of questions, and will be teeing these up for me.
All right. Well, thank you, Dr. Winkleman. We'll go ahead and get started so we can get through as many questions as possible. First question, has there been any research done on neurostimulation and circadian rhythms and/or circadian rhythm disorders?
I have seen nothing on neurostimulation in treatment of advanced sleep phase or delayed sleep phase. I could potentially imagine that would be helpful, but I haven't seen any data on it, but I haven't really investigated it either.
Okay. Does trying one of these devices require a tapering off of current medications, or can you switch immediately?
I would discourage people from ever discontinuing medications abruptly, because you will suffer, and it's just a mistake. When we change medication doses, medications that work in the brain, we always make no fast moves. Always do it slowly. And here, if you were going to be investigating the effectiveness of neurostimulation, what I would do would be to continue taking normal medication, use the neurostimulation if that's what you want to do, and then gradually, over a matter of weeks or even months, gradually reduce the dose of the medication. So never abruptly stop RLS medicines, because RLS, unfortunately, comes back with a vengeance. And then you may think the other treatment didn't work, and it really may just be rebound of RLS symptoms.
Okay. Let me turn page here. Are any of these therapies covered by Medicaid or Medicare, or are they still experimental? Success with Tourette's or apnea?
You slipped that last one in there really quickly, so there's two sets of questions here.
Yeah, it was the same question, but maybe
yeah,
they have
although completely different
underlying conditions.
Yes, so
it sounds like
Medicare or Medicaid, no. If you have peripheral neuropathy, I think Medicare covers some of the TENS devices. I'm pretty sure that it does. The other devices, I think you will get no coverage from Medicaid or Medicare. Then the question is effectiveness in sleep apnea or Tourette's.
Correct.
I have no clue, and I would seriously doubt it.
Okay. Next question. Have you heard of CBD oil distributed by CV Sciences as a nutritional supplement? It has been recommended to me for use in RLS.
CBD oil?
CBD oil.
Okay. I think that CBD is one of the components of marijuana, and I have many patients, or a number of patients, who are using marijuana for restless leg syndrome, but I know nothing about that particular brand of one of the components of marijuana, so I probably best for you to ask somebody else about that.
Okay. What has been your experience with using copper bracelets as a treatment for RLS?
I have no experience with that. I think that there's no published data. All you can lose is one, time and a little bit of money. So it's, I guess, a question of how valuable is your time and how valuable is your money. To my feeling, you probably want to try to use approaches that have had proven effectiveness. But if you don't mind waiting for some period of time and continuing to have your symptoms to see whether the copper bracelet works, it probably can't be that expensive, and so I think that that's up to you and depends upon the kind of person you are and how patient you are about waiting to see effectiveness.
Can any of these treatments used to help with DAWs?
Help with DAWs? No, not as far as I know. I think, DAWs, which is dopamine agonist withdrawal syndrome, is, in my experience, not that common. Certainly people have RLS rebound, and really bad RLS rebound, when you taper the dopamine agonist too quickly. The mood syndrome that develops, I haven't seen that often, although I have seen it at times. And it's a really tough thing to manage. I think just going back on the dopamine agonist and going very, very slowly and getting under the care of somebody who's knowledgeable is the best approach for that.
Okay. Have any of these modalities been tried on mast cell patients who are often triggered by vibration?
On what kind of patients?
Mast cell patients, it's a syndrome where they have excessive release of chemical mediators in response to a stimulus.
I don't know. You have to understand, I'm a sleep doctor, and so I don't know about that, and I think the most valuable thing I can say when I don't know is I don't know.
Okay. Next question then is there any use of these neurostimulation devices in treatment of people with PLMS?
It's a good question. As far as I know, none of the studies looked at PLM in using polysomnography. It's possible one of them did. I think the bigger question is, to what extent do periodic leg movements of sleep require treatment? Because that's a really controversial area and has been for 20 years. Those leg movements are oftentimes subtle. Sometimes they're much more robust, but oftentimes they're subtle. And there isn't great evidence that periodic limb movements of sleep predict sleep disturbance. And so I think we need to be cautious about jumping into treatments of periodic leg movements. If they are waking you up, if they're significantly disturbing a bed partner, then certainly I think you want to try to influence them. But as far as I know, there have been no studies with neurostimulation techniques looking at PLMs.
Okay. Which method, I'm assuming neurostimulation, has been shown to be the most successful so far? And are there any side effects to these treatments?
So I think the ones that are closest to being ready for prime time would be the pneumatic compression devices for RLS. The Relaxis device does not work for RLS, but did help with sleep. And I'd say the near-infrared stimulation, at least in the one study that was done, the one controlled study that was done, did have some good results. So I'd say those two are probably the closest to having reasonable data that they're effective. Potentially transcranial magnetic stimulation. TMS needs to be done in a clinical setting, and I doubt that it would be covered by insurance, so you'd need to pay for that. The pneumatic compression devices you can buy over the internet, and so the only side effect there really is the cost. The near-infrared stimulation, again, can be done either in a clinical setting, or you can buy near-infrared stimulators on the internet. They're pretty expensive, and then you can try to mimic what was done in these trials. But I don't know of any specific side effects associated with any of those treatments. But certainly the last thing you want to do is try to build one of these things at home and try to stimulate your brain or your spinal cord or your peripheral nervous system, because that could potentially be dangerous.
Okay. Does a temperature increase cause more RLS stimulation?
I think that would mean more RLS symptoms. I've heard both. I've heard people who have more RLS in hot weather, but I've also heard people who have treated their RLS by using hot water, hot shower, hot bath. So interestingly, I think that this may be an individual response that people have to heat, and I think therefore you have to judge based upon your own particular response.
It's an interesting question that we get at the foundation, and I'll just add, we see, especially this time of year with cold and flu going around, people tell us that their RLS symptoms decrease when they have a febrile event. Do you notice? Have you heard that as well from your patients?
That's interesting. Only when they have a fever, you think?
Right, and they're kicking around a good 102, 103, 104 temp. You know, they said they were really sick, but the upshot was they didn't have RLS symptoms.
Interesting. You know, I think I've rarely heard that. That kind of fever, 102, would be very unusual in with just a regular upper respiratory infection in an adult. In young people, they can mount that kind of febrile response. That's really uncommon as people get older. But I think that is an interesting point, and whether that could be mimicked in other ways, I think would be worth pursuing.
Okay. Another question on another device is, what are your thoughts on non-medication options like Restifik for RLS?
You know, I should have probably put the Restifik here in this talk, and I apologized for those people who wanted to see data about that. I apologize for not including it. You know, I've seen some of the Restifik data, and it is a very simple device that applies kind of pressure to the bottom of the foot. And their data was, as I recall, was open label, or else the sham was a not convincing sham, and therefore I think we can't consider that to be really convincing scientific data. But again, this is a very low cost, easy intervention that may be worth a try for people. I think the biggest concern I would have with things that you'd strap on to the bottom of your foot would be, I would just be really cautious to make sure you take it off before you, if it's not working, make sure you take it off before you get up and start walking around, because people will fall down and get hurt. But I think it's worth investigating in traditional scientific methods the value of that particular device, and it to be done by somebody other than the company who's selling it. Carla, you still there?
I'm still, I'm writing down notes, so it kind of takes me a while to get that,
okay, I'm sorry.
to pop around.
I just was worried that you had gone away.
Oh no, no weather events here today in Austin. Is the use of V-light and intranasal light therapy helpful?
What was the first kind of light?
VIE light. It's an intranasal light therapy. Is that helpful?
Never heard of it.
Okay.
Never heard of it. Never seen anything published on it. Light inside of your nose. Mm-hmm. Wow. The things that people will do, I'm trying to think how that would be helpful. Why would that be helpful for restless leg syndrome? I could see why applying light to the legs might have some vascular effects, but why would sticking light in your nose be helpful? I've never heard of that, but I'll have to look it up and see what it is.
Mm-hmm. All right. Let me just go some more. We've answered a couple of these on TENS. And, you know, a lot of people were asking for further comment on why TENS are effective as a treatment for RLS, if you wanted to kind of re-review.
TENS actually stimulates at the tibial nerve. So it's providing current across the skin to a point where the nerve is close to the skin, so you don't have to apply a lot of current because it's close to the skin there. And either it has its effects by directly stimulating the nerve, therefore shutting down other impulses that are coming from that nerve. This would be the counterstimulation effect. Or there's some hypothesis that it has a systemic effect by releasing endorphins, and that the endorphins are actually the mechanism by which the RLS is relieved. I don't know whether there's any evidence proving either of those approaches, but those are the theories as to why TENS works. You know, we don't really have great insights into why the medications work. The dopamine agonists act like dopamine at the synapse, but beyond that, why do they work? Well, I don't know. Gabapentin, or gabapentin menocarbyl, how does that work? It works at alpha-2 delta calcium channel sites across the nervous system, but how would that make RLS better? I don't really know. Even with iron, we are increasing levels of iron in the brain if we give it either by mouth or by IV. And how does that help RLS? I'm not sure people know either. So we may have some of the very superficial, kind of the first step of why these things work, either medications or these devices. But beyond that, it's really kind of a black box.
Mm-hmm. Kind of piggybacking on to your TENS question is, do you recommend using TENS unit during active symptoms or just at regular intervals?
Right at this point, I'm not sure that I can actively recommend TENS. We did that one study, but as I hope I was clear, it's a low level of evidence because everybody knew they were getting what we thought might be an effective treatment. So it was not placebo or sham controlled. I would say that when people used it, they used it in the evening. Some of them used it throughout the night. So there was sometimes before symptoms began, but oftentimes during the period when symptoms were active.
Okay.
My Sudafed is wearing off, and I'm getting very sniffly.
Oh, sorry. Do you need to take a break
Okay.
or get a drink?
No. Nope,
okay.
I'm good.
Okay, next question then. What's the best way to participate in a clinical trial for any of these non-pharmacology approaches?
Well, you need to identify who's doing one of these studies. And I think that there are probably very few people that are, because the studies are hard to do because they require quite a bit of financing. There's a lot of time on a research coordinator and the principal investigator's part. You have to submit lots and lots and lots of paperwork to the hospital to get approval, and then you have to get devices and reimburse people. And so, unfortunately, there is not a lot of investigation in this area. I wish that someone would come forward who had an interest in this area and say to me, I'd really like to investigate X, Y, or Z treatment, and I will provide the funds to do that, because we can answer some of these questions. I certainly know how to do these trials, but without funding, I can't get them off the ground. I think that if you're truly interested in participating in one of these studies, and you can't afford to support the study yourself, to fund the study yourself, probably the thing to do would be to go on to clinicaltrials.gov and see whether there are any of these and once you get onto that website, this lists all the clinical trials that are happening in the United States. And then put into the search bar restless leg syndrome, and there won't be a lot of trials there, and search down the list and see if there are any that involve any of these types of devices that you might be interested in. and then see if whether those sites are convenient for you to participate. So it's kind of a long-winded answer, but we certainly need more investigation in this area. I did want to do a much larger trial with TANs using a sham comparison, and we had everything all set, the protocol written, but we just could not find the funding for it. And so it's really at this point on hold, waiting for somebody to fund it.
So another question that kind of piggybacks onto this is how do we raise awareness of RLS so that we can get funding for research across the board?
Well, I'd say the first thing you want to do is support the RLS Foundation, because this is the goal of the RLS Foundation. You shouldn't try to reinvent the wheel, I don't think. There are other people whose job it is to raise awareness about RLS and try to raise funds for novel treatments and novel approaches. So I think supporting the RLS Foundation, if you think that there's a particular investigator who you think is motivated, knowledgeable, and going to be effective, you could support them individually through their hospital, because that would also be provide tax deduction benefits, at least for now. And I would say starting a local support group in your community would be a good thing to raise awareness. Talking to the sleep doctors and neurologists in the area who see such patients and letting them know about the support group would be valuable. I think all of these are ways to raise awareness and improve treatments for people with RLS.
Well, I'd also like to let everyone know that the Foundation funds the only dedicated RLS research grant program with 100% of your donation going to fund researchers whose sole purpose is to find better treatments and a cure for RLS. So if you don't know, we've increased our awards to $200,000 a year, or up to 8 grants. So we're seeing some very high quality grants come into the program, but the more money we have, the more that we can fund. So I ask you, to I have a child with RLS, and so this is first and foremost to me in my life, is to find that cure for her in her lifetime. So I know everyone who's out there who lives with this disease feels the same way, and our researchers are just as passionate. So you know that your money's going to be put to good use. But before we let you go, Dr. Winkelman, I'd like to know what you're working on and if you see a cure for RLS in the future.
So currently I continue to do my research looking at the cardiovascular aspects of restless leg syndrome, trying to assess whether RLS, like sleep apnea, is a risk factor for cardiovascular disease, in particular myocardial infarctions or heart attacks. So that's one area. The second area that I'm currently working on quite actively is looking at RLS that develops in people who use opiate medications and then withdraw from those medications. We just published a study showing that 50% of people who used opiates, and these were people who were using them inappropriately, they were in a detox unit, as they were coming off of the opiates, they they met criteria for restless leg syndrome. And the concern, of course, is that as they come off the opiates and they get RLS, that given that they couldn't find any other way to deal with this really bad RLS that they have, they would feel that they would have to go back to using opiates, and that this could just increase or decrease people's ability to stop these medications. So we're expanding that research now. and trying to see how long that RLS symptoms go on, whether they continue when people are on long-term therapies like Suboxone, which is an opiate that's used for people with opiate addiction, and then hopefully apply for money where we can investigate whether usual treatments for restless leg syndrome are effective, whether they be dopamine agonists or alpha-2 delta agents like gabapentin nanocarbyl, or pregabalin, whether they're effective for people who have opiate withdrawal-induced restless legs, because that would be then a way to treat it while they're susceptible to those symptoms without them needing to go back onto the opiates. So that's the second area. And then the third area we're involved with a multi-site study looking at intravenous iron treatments, and I think that those show promise, but at this point in time it's unclear who will benefit and how long they will benefit. So there's a ton of stuff that's going on in RLS, not just with my group, but with other groups in the United States, Europe, and Japan, and outside of those areas as well in the world. My belief that we'll find a cure is, I have some hope, but at this point in medicine in the 21st century, we really don't cure much. What we do is we manage chronic illness. And we've gotten pretty good at managing a lot of chronic illnesses, but there are very few healthcare professionals who can say that they cure things. Maybe if you take an antibiotic, or if you go to a surgeon and they cut some part of your body out, but cures are elusive. At this point in time, I'm just hoping for better management tools so that people don't have to suffer as much.
All right. Well, I'd like to thank you, Dr. Winkleman, for sharing your expertise with the attendees on today's webinar. I just want everyone to know our next webinar is scheduled for March 9th with Dr. Becker. Please visit our events page located on the website to register and learn more about upcoming webinars. And I thank you, Dr. Winkleman, for spending, going over and answering these questions. And I'm excited, as well as everyone else is, to hear about your RLS research. And we hope to have you back again. It was an awesome webinar. Thank you so much.
Always a pleasure to join you. Thank you, Carla, for the work that you do too.
Well, thank you. I love my job.
So do I. Right. Isn't that nice?
It is nice because I'm passionate about this cause. We're getting there. All right. Yep. Well, thank you, everyone. Have a good afternoon and feel better, Dr. Winkleman.
Thank you, Carla. Bye-bye.
Bye-bye.